This is QD Clinic. QD Clinic is brought to you by RheumNow.live 2025, Dallas, Texas, February 8th and 9th. You can be there, but you know what? You can be there from home. Virtual registrations are still open. It's going to be a good program. Today's case is new onset palmoplantar psoriatic arthritis. 41-year-old woman comes in with a 1-year history of palmar and plantar scaly red lesions, went to her dermatologist, was given a wrong diagnosis, went to another dermatologist, called palmoplantar disease, given steroids, and was referred to the big shot medical dermatologist in town. But prior to seeing that person, she gets an appointment with me because she's also having joint pains. So in addition to these refractory lesions on the palms and the soles, she has a few other rashes on the body. She's got arthralgia, swelling, stiffness, sausage-like changes in her fingers with stiffness and pain. And that's pretty much it. It's mainly in her fingers, nothing in her toes, nothing in her spine. She denies any other medical problems other than asthma, and she has no other medical problems going on. She has a little bit of fatigue. That's about it. She comes in today complaining of the rash, stiffness and swelling in fingers, PIPs, and wrists, up to 2 hours of stiffness in the morning. Her pain is 3 to 4 out of 10. Again, she's only taking Tylenol. She tried taking nonsteroidals, Aleve, but it gave her gastritis, and she cannot tolerate nonsteroidals. She's taking medicine for her asthma. When you see her, she's got normal vital signs. She's got scaling and redness to the palms, more so than the soles. She has plaque psoriasis on her extensor arms and a little bit on the ankle and elbow. So it's kind of plaque psoriasis with mainly a palmoplantar presentation. When you do the joint exam, she has no deformity, no nodules. She has tender joints. She has up to 11 tender joints. And she has swelling of the PIPs bilaterally 2 through 4. She has some heel pain. And that's about it. Her Schober's test and spine exam is normal. So, only labs that I have on her was a normal CBC chem profile, a negative rheumatoid factor, and negative quantiferon test. Not sure why that was done, but that was a good idea. So she has active skin disease and merits treatment for that. She also has active arthritis and merits treatment for that. So if I was treating this, my diagnosis is clear. I know I can't manage her with simple nonsteroidals, and I don't want to use steroids in a psoriasis patient. Her options are TNF inhibitors, IL-17 inhibitors, the 12-23s, the 23 inhibitors. She has probably too many joints and dactylitis, enthesitis that I probably wouldn't want to use apremilast in this person. And when I saw her, I said, go talk to the psoriasis expert in Dallas and see what they recommend. But I do recommend that you start on either adalimumab or an IL-17 inhibitor, or that you go on a gluten-free diet. At the time I saw this patient, my partner and I, we were doing a lot of gluten-free diets in patients with psoriatic and spondyloarthritic disease and getting great results. I mean, I've seen people with more joints and swelling than this gal, who I told to take adalimumab plus 40 milligrams a day of leflunomide, a double dose, plus steroids, and go on a gluten-free diet. And that gentleman went on the gluten-free diet and nothing else. He didn't take the biologic or the DMARD or the steroid, and he came back 4 months later with no psoriasis, and he had palmoplantar disease, by the way. No psoriasis, no arthritis. So I know we can argue about the value of a gluten-free diet and anti-inflammatory diet. We recommend totally gluten-free and as carbohydrate-free as you can get. And we feel that's as good as being on a Mediterranean diet. And that works really, really well in spa in PsA. It doesn't work in other inflammatory arthritis, in my opinion. Anyway, she did go to the dermatologist. She did want to try a gluten-free diet, and she did get better, but ultimately needed a biologic. And she was put on an IL-17 inhibitor because the dermatologist felt that it was probably a little bit more effective than the TNF inhibitor in what is difficult to treat psoriasis, which is Palmoplantar disease. The patient did well. That's the end of the story. You can tune in from home and register for virtual RheumNow.live coming up in but a week. We'll see you there.